Hello. On behalf of SOE, the European Society of Ophthalmology, I would like to welcome you to our SOE webinar on how to prevent myopia onset and reduce myopia progression. I am delighted to moderate this webinar with Professor Vagik Aklimandas, the president of the SOE. Before we begin, I want to run through some quick housekeeping items. Audience questions. You can ask questions via the question and answer part of the service, and we will be looking at them and trying to answer as many audience questions as possible. If you have a particular question after this webinar that was not answered, please email to soewebinars@soereason.org, and we will try to answer them in a separate document, which will then be accessed via the SOE website. The webinar is being recorded and will be available later via the SOE website and placed on the SOE YouTube channel. I would also just like to talk you through the running order for today. All talks will be presented, and this will be followed by a question and answer session at the end. If you would like to ask a question, simply submit it via the question answer section on Zoom. The main aim of the webinar is to provide information and guidance for eye care practitioners how to prevent and manage the development and progression of myopia. To get the webinar started, I would like to ask you all to participate in a short poll. And now for question 2. Now for question 2. May I deliver the mic to our president, Vagik Aklimandas?
Thank you, everyone, for participating in the polls. I can see that we have a wide range of professions and participation from around the world. Welcome to you all. It is unfortunate that we have been unable to meet face-to-face at the Congress in Prague as initially planned, but times have been hard. I do hope that this series of webinars will go some way towards fulfilling the SOE mission of education, discussion, and sharing of information. I sincerely hope that by the time of the next Congress in 2023, we will be able to have those discussions face-to-face over a cup of coffee or a glass of wine. This afternoon's webinar on myopia is an amazing achievement by János, and I will say more about him later. Myopia is no doubt a hot topic, and quite rightly so. High levels of myopia are very incapacitating, and large myopic eyes are at significant risk of problems throughout a person's life. We are very privileged to be able to moderate, modulate, prevent, or slow down the progression of myopia. There are many exciting developments that we shall hear about today. Like with any new developments, there are, of course, some controversies. I hope that you will find the webinar informative and it will have an impact on your practice. Please feel free to send your questions to the speakers. I must thank again my co-moderator, János Nemeth, who I will introduce more in detail when he's about to deliver his talks. And I'm very grateful to the support we're getting from the SOE staff, Joe, Hannah, Anne, and all the hard work that is put into delivering and organizing this sort of SOE webinars. János has put together an excellent panel of speakers, and I would like to thank each and every one of them for the time and effort and for sharing their outstanding knowledge and experience in this field. So I would like to hand over to János to introduce our first speaker, please.
Okay, dear President, dear colleague, I would like to say a few words as an introduction. So the webinar is mainly based on the published updated guidance on management of myopia by the European Society of Ophthalmology in cooperation with International Myopia Institute. This guidance was published in the European Journal of Ophthalmology early March in this year, and it is open access, so you can reach it free of charge in the full content. So pathological myopia is predicted to become the most common cause of irreversible vision impairment and blindness worldwide and also in Europe. Here you see the predicted increasing further tendency in Europe unless we act now. And we have to act now, and we have the effective interventions which are described in the guidance, and also will be shown during this webinar. So the main aims of the webinar is to increase awareness and to provide guidance for eye care specialists to prevent myopia onset and to reduce progression of myopia. Here you see the lectures. The webinar consists of 6 lectures after the introductions. So histology of myopic eye will be presented by Professor Jonas from Germany. And unfortunately, Serge Resnikov, professor, is not able to join, so I will present the epidemiology of myopia. And Professor Kristina Vidinova from Bulgaria will present environmental risk factors and their optimization possibilities. And Professor Andrzej Zrybowski from Poland will present pharmacological interventions. And Dr. Beata Tapasto from Hungary on optical interventions and combination therapies. And then I will show a short summary about our guidance. And at the end, there will be 20 minutes for questions and answers. So we are waiting at the end your questions. As an introduction, I would like to show you some important definitions, which the definition is of myopia is very well known. It is a refractive error in which rays of light entering the eye parallel to the optical axis are brought to a focus in front of the retina when ocular accommodation is relaxed. So the qualitative classification is that there are axial myopia, where the axial eye length of the eye is longer than the normal, and refractive type, where the changes in the structure of or location of the cornea or the lens causing the myopia, and there are some secondary forms as well. Most important is the quantitative classification in this webinar, and in the guidance we are speaking about myopia if the spherical equivalent refractive error is equal or less than -0.5 diopters. And about low myopia when it is between -0.5 and -6 diopters, and high myopia when it is less than -6 diopters. The important term is the premiopia in children around the age of 6, when the refraction is less or equal to plus 0.75 diopters, but more than -0.5 diopters. That is the baseline refraction. At that age, and other risk factors provide a sufficient likelihood of the future development of myopia. So the pathogenesis. Myopia onset and progression is a result from a complex interplay of visual, environmental conditions, and genetic factors that modulate the eye growth. Retinal defocus initiates a signal cascade that leads to a number of cellular and biochemical changes in the retina and in the retinal pigment epithelium. These chemical signals are transmitted through the choroid. The choroid releases growth factors that have the potential to regulate scleral extracellular matrix remodeling and leading to increases in ocular growth and a more myopic refractive state. Myopia is caused by a complex interplay between genetic and environmental factors. To date, more than 600 genetic loci have been identified for refraction and myopia. Persons at high genetic risk have an up to 40 times increased risk of myopia compared with persons at low genetic risk. Secondary syndromic forms of high myopia, such as Marfan's, Stickler's, and Donné-Barrow syndrome, are inherited predominantly in a Mendelian fashion. Therefore, a clinician should be aware of their syndromic features, and extensive ocular examination should be performed in case of a young onset of myopia or clinical suspicion. So thank you very much for your kind attention, and I wish you a pleasant webinar viewing. Thank you. We will move on to our first speaker, Josby Jonas, who will discuss histology of the myopic eye. Professor Jonas is working in the Department of Ophthalmology at Heidelberg University in Mannheim, Germany. Please.
Dear Chairman, ladies and gentlemen, it's an honor and pleasure for me to present this talk on the histology of the myopic eye. Please see here my financial disclosures. Going for the histology of the myopic eye, one first looks on histological changes in the macula In the framework of the myopic maculopathy, as we can see the patchy atrophies in these two examples. Going into histology, one sees that there are areas without Bruch's membrane, so that some of these patchy atrophies correspond to a macular defect in Bruch's membrane, shown by the red arrows here, surrounded by a larger area without retinal pigment epithelium. Here a higher magnification, where the blue arrow indicates the end of the retinal pigment epithelium, and the two yellow arrows indicate the end of Bruch's membrane at the end of such a patchy atrophy. Also in OCT histology, one finds that the patchy atrophies in myopic maculopathy correspond to defects in the retinal pigment epithelium and in Bruch's membrane. Second, there are myopic changes in the optic disc, particularly the so-called secondary macro discs in highly myopic eyes. Going into histology, one finds that there's not only an enlargement of the optic disc, but also an elongation, probably stretching and clearly thinning of the lamina creprosa, leading to a decreased distance between the intraocular cavity and the retrobulbar orbital cerebrospinal fluid pressure compartment, so that the decreased distance between both compartments leads to a steepening of the translaminar creprosa pressure gradient, which may be one of the reasons for the increased glaucoma susceptibility or increased susceptibility for an optic nerve damage in highly myopic eyes. The laminar creprosa can become as thin as 50 micrometers in highly myopic eyes, as shown in this example. As pointed out before, the prevalence of a glaucomatous or glaucoma-like optic neuropathy, as shown by the vessel kinking close to the optic disc border in these examples, increases markedly with longer axial lengths in the highly myopic group of eyes. The prevalence can go up to 80% in extremely axially elongated eyes. There are also changes in the parapupillary region of highly myopic eyes, particularly the alpha, beta, gamma, and delta zone. Alpha zone has been defined as a region with Bruch's membrane present and with irregular retinal pigment epithelium, as shown on the right slide between the white and a red arrow. And beta zone is characterized by the presence of Bruch and absence of retinal pigment epithelium. Looking for the etiology of beta zone, studies have suggested that fluctuations in intraocular pressure lead to a piling up of the RPE, retinal pigment epithelium, at the optic disc border, as shown in the lower slides in this example, in an eye which experienced an IOP rise due to a darkroom adaptation test. And it appears that also beta zone, as shown in these infrared images, enlarge if you compare the superior and inferior image. Interestingly, in routine histology, one finds not quite rarely drusen of the retinal pigment epithelium at the optic disc border, potentially the surrogate of this piling up of the RPE. Also in routine OCT histology, one finds such piled up RPE even in normal eyes. Besides alpha and beta zone, there is gamma zone, typically in myopic eyes, and defined as a parapupillary region without Bruch's membrane, here between 3 and 4. Upon ophthalmoscopy, one can also see the gamma zone, as shown here, between the demarcated by the black arrows. And then there is delta zone. Delta zone is the elongated and thinned peripapillary scleral flange, which normally makes out about 50% of the posterior sclera and connects the sclera with the lamina creprosa. In highly myopic eyes now, as shown on the lower right image, the scleral flange can be elongated by a factor of 10, and its thickness can be reduced to about 10%. And since the scleral flange is a biomechanical anchor of the lamina creprosa, any changes in the flange, called delta zone, may correspond to biomechanical changes in the lamina creprosa. Looking now for the etiology of gamma zone, and going back to the clinics, one sees here an adolescent, a medium myopic person, where gamma zone increases while simultaneously the disc shape changes from a circular form to a vertically oval form. This has led to the hypothesis that in moderately myopic eyes, gamma zone develops due to a shift of postmembrane opening into the temporal direction, leading to an overhanging of postmembrane on the nasal side and an absence of postmembrane on the temporal side. This can also be seen in OCT histology with the overhanging of postmembrane on one side and the lack of postmembrane on the other side. Also in normal histology as shown in this example. And here another example with an oblique optic nerve exit, which is nothing else than potentially a shift of postmembrane opening in direction to the fovea. A second mechanism leading to gamma zone may be a general enlargement of the postmembrane in highly myopic eyes, leading to a circular gamma zone and thus to an enlargement of postmembrane opening, often but not always in association with an enlargement of the optic disc itself. This is shown in the lower part of this slide, where postmembrane enlarges circular, leading to a circular gamma zone and also to a widening of the stretching of the lamina cribrosa. Interestingly now, highly myopic eyes, which had a larger BM opening zone, had a lower prevalence of secondary macular postmembrane in the macular region. Then there's a peripapillary ring, as shown by the black arrows here. Upon histology, this ring may be the continuation of the pia mater of the optic nerve, which continues into the peripapillary border tissue of the scleral flange, which then continues into the peripapillary border tissue of the choroid, which then finally connects to the end of postmembrane. From a biomechanical point of view, the whole inner part of the eye, consisting of uveas, postmembrane, choroid, and retina, is connected to the sclera only by two structures, the scleral spur on the anterior part and the peripapillary border tissue of the choroid at the posterior part, so that this border tissue may have biomechanical importance. The border tissues can also be seen on routine OCT histology as shown here. And of course, gamma zone leads to a lengthening, stretching, and thinning of the peripapillary border tissue as shown here. This perhaps may be associated with the piling up and focal thickening of the photoreceptor layer as shown here by the white arrow. And here another example where perhaps the peripapillary border tissue normally connecting the end of postmembrane with the optic disc may be ruptured due to the large wide gamma zone. And if it's ruptured, postmembrane end may become loose, leading to the corrugation of postmembrane as shown in this example. Then looking for the underlying histology of the mechanism of the process of ametropization, one finds first, as we all know, axial elongation is associated with the thinning of the choroid. Second, axial elongation means mostly an enlargement of the globe in sagittal direction, while the horizontal and vertical disc diameters increase only by 0.1 or 0.2 millimeters for each millimeter elongation in the anterior posterior direction. As we know, the sclera becomes markedly thin, but mostly at the posterior pole and not at the ora serrata or anteriorly. The scleral volume does not change after the age of 2, and the volume is independent of the axial length. Same findings have been obtained with the choroidal volume. In contrast, the thickness of the postmembrane is independent of axial length, so that its volume increases with axial length, suggesting that perhaps postmembrane may be actively involved in the process of axial elongation. Then, eyes with a congenital defect in postmembrane, as these eyes with colobomas, have a localized scleral staphyloma, suggesting that perhaps postmembrane may be the primary structure giving form and shape to the eye. Eyes with a secondary defect in postmembrane, as this eye with a toxoplasmotic scar, also show a localized scleral staphyloma. Again, fitting with the notion that postmembrane may be a biomechanically important structure. Interestingly, the choriocapillaris, which is adherent to postmembrane, may be also in its thickness independent of axial length. Now, the distance between the disc and the fovea increases with longer axial length, but only due to the development of gamma zone, while the length of macular postmembrane itself, defined as the distance between the fovea and the peripheral border of gamma zone, is independent of axial length. Also, the density of the retinal pigment epithelium cells in the fovea is independent of myopia, while in contrast, the density of the RPE in the mid-periphery, as also the retinal thickness, decrease with longer axial lengths. As shown here, also the retinal thickness in the fovea is independent of axial length, while in the periphery it decreases. How can all these histological findings now put together? It led to the speculative hypothesis that the myopic axial elongation occurs by the production and elongation of postmembrane in the equatorial region, leading to a backward push of the macular postmembrane posteriorly, to a compression and secondary thinning of the choroid and a secondary thinning of the sclera. If this notion is correct, then postmembrane should have biomechanical strength, and indeed, it needs a pressure of about 80 to 100 millimeter mercury to make postmembrane burst. Also, if one has a wide-angle view on the fovea, one has the impression that myopic axially elongated eyes have in particularly a lengthening of the fundus periphery. And also this change in the eye shape from a sphere to an prolate form can easily be explained by an additional wall production in the equatorial region. So that in conclusion, from a histological point of view, postmembrane may be more than just an almost invisible double basal membrane with some collagen and elastin in between, and may be perhaps involved from a biomechanical point of view in the process of axial elongation. Thank you very much.
Thank you very much, Jos, for this excellent presentation. Really thought-provoking. I mean, it is fascinating to get this in-depth view in the details at a microscopic level of conditions we see every day, and sometimes we forget what's the underlying cellular pathology we're looking at. That was a fantastic demonstration of how histology can be really interesting. Thank you. Now, I have the privilege of introducing our next speaker, who has already been partly introduced because he's the co-moderator of the session, and he has given a fantastic introduction. You will have gathered from what he has already said that János Nemeth is an outstanding speaker. He's a full-time professor and scientific vice director in the Department of Ophthalmology at Semmelweis University in Budapest, Hungary. He has always been interested in epidemiology, and his PhD thesis was actually in the early diagnosis of glaucoma in 1991. And his DSc thesis was on blood circulation of the eye and orbit in 2003. He has taught generations, 40 years of dedication to teaching. He's a prolific scientist who has published 381 scientific papers in high-impact journals. He's also authored 10 books and 40 book chapters. It is hard to imagine what more he could do, having already given over 800 lectures at an international level. He's also a fellow member of the European Academy of Ophthalmology. He is a founding member of the Southeast European Ophthalmological Society. He has been heavily involved with virtually every society, but most importantly to me, it's been such a privilege to work with him on the board of the SOE, where he has been a real engine. And it's been a pleasure to produce together the published guidance on management of myopia that he mentioned earlier. János has also been heavily involved with the ICO, the American Academy, the ARVO, and he has been president of the International Agency for the Prevention of Blindness from 2012 until 2021. short of making a whole talk on Janos, I have to stop and ask him to deliver the second talk of the webinar. Thank you.
Dear colleagues, I would like to give a short summary of epidemiology of myopia. Based on the World Health Organization World Report on Vision, which was issued 2 years ago, there are 2.6 billion people with myopia in the world. So that is the most frequent condition, eye condition, all over the world. So, and here you see the tendency of the myopia, which is increasing very much in time. And by the years of 2050, it will almost reach 5 billion people with myopia. And on the lower line, you see that there is also an increase in the high myopia. And the number of people by the time of 2050 almost reach 1 billion people. So pathologic myopia with myopic maculopathy and associated optic neuropathy in highly myopic eyes can cause significant irreversible visual impairment and blindness, and predicted to become the most common cause of visual impairment and blindness worldwide and also in Europe. So it is predicted that by the year 2050, almost half of the world's population will be myopic and around 10% will be highly myopic. This increase has a huge medical and financial impact and importance. Here you see the increasing prevalence of myopia for East Asian countries. The importance of the marked increase in the prevalence of myopia has been well documented, and in particular in East Asia, as the East Asian countries have experienced by far the most pronounced increase in the myopia prevalence compared to countries in other world regions. Consequently, the experience in preventing the development and progression of myopia in children and adolescents is more advanced in Asia. Here you see the European data, which are a little bit lower, but also increasing very much in time. There are regional differences between Western, Central, and Eastern Europe, and there are other differences geographically in Europe, like that this trend, this increasing trend line seems to be absent in Norway and Denmark. But if you see this, that the European trend prevalence numbers are lower than the East Asian, this is still very high. And by the time of 2050, it will be more than 50% of the population. So it's high, and unless we act now. So the prevalence in different age groups. The highest rate of onset of myopia is currently observed in children aged 7 to 10 years. An early age of onset of myopia appears to be the strongest predictor of high myopia. So also, if we are able to postpone the onset of myopia, it will result a lower chance to be highly myopic. Myopia generally progresses most rapidly during the pre-teenager years, between the age of 7 to 12 years. Here you see the trend lines in children for East Asia, blue dots, and in Europe, red triangle. And you see that around the age of 5, there is almost no myopic prevalence or zero prevalence, but it increases very much in East Asia, up to 90% by the age of 20 years, and in Europe increases above 50% by the 20 years old age. Around half of the myopic children are stabilized by the 15 years of age, and there is evidence for myopia to have stabilized in most myopic individuals by the age of 24 years, except high myopes. Here you see the prevalence of myopia in France in different age groups, and note that the highest prevalence of myopia, more than 50%, is in the age group between 20 and 30 years. We also examined the distribution of refractive errors in Hungary in a large population aged between 18 to 99 years. And we found myopia, the most frequent refractive error, more than 43% of the population had myopia. And if you see the mean refractive error in different age groups, there were myopic refractive mean error in the ages below 44 years, and then there were a decade where the refraction was close to the emmetropia, and then above 60 were hyperopic refraction, and above the age of 75, again, a low myopia appeared. And if we see this distribution of the refractive errors in different age groups, myopia, emmetropia, and hyperopia, the relative distribution showed here. And in the younger age groups, so the generation who was born after 1970, there are more low myopes in this younger age groups than in the earlier generations. So the distribution showed that around 50 to 60% of the young are myopic. And in the older age groups, there are less myopia, and there are more hyperopic persons, and it is also due to the hyperopic shift during the aging. And again, above the age of 76, there are more low myopes, and it is due to the nuclear sclerosis and also the results of intraocular lens implantation. So as a summary, the prevalence of myopia in younger generation is already 50 to 60% in Europe. Further increase in the prevalence of myopia and high myopia is expected if we do not act now. Introduction of European and national programs are mandatory to implement the evidence-based myopia control interventions. Thank you very much for your kind attention. I would like to welcome our next speaker, Kristina Vidinova, who will discuss environmental risk factors for myopia development and their optimization possibilities. Professor Vidinova is working in the Department of Ophthalmology at the Military Medical Academy in Sofia, Bulgaria. Please, Kristina.
Dear colleagues, my name is Associate Professor Kristina Vidinova from the Military Medical Academy, and it is my pleasure to be in the SOE webinar talking about the environmental risk factors for myopia development and the possibilities for their optimization. Nowadays, myopia is not only a benignant error of the refractive power, but it is a worldwide epidemic with significant health consequences. It is believed that the prevalence of myopia is growing globally, and by 2050, it is predicted that half of the world's population, about 5 billion people, will be myopic, with nearly 1 billion at risk of myopia-related ocular pathology. What do we mean by this? High myopia is actually a higher risk of serious complications. You see that people of about 6 to 8 diopters are 5 times with more risk to be with a cataract, with 21 times more risk to be with retinal detachment, and 40 times greater risk to be with myopic maculopathy, which is a serious complication. What are the risk factors actually for myopia and how it develops? Myopia is a complex process, and there is a complex interplay between genetics and environmental factors. Actually, it is not known which is more important, the genetic or environmental factors. You see, genetics are very strong, and if you have 2 myopic parents, then the risk for the child to develop myopia is 6 times greater than usually. But this is not everything. Risk factors for myopia can be summarized as following: age of onset, ethnicity, gender, personal characteristics, and also time spent outdoors, education, and binocularity. It is very important if we can identify the children who can be and who are pre-myopes. There are 4 key principles to assess the risk of myopia. One of them is family history, of course, but most important is the visual environment, and especially if this child has less than 90 minutes a day spent outdoors, this increases the risk for myopia development, especially if it is combined with more than 3 hours a day spent on near work activities. Also, binocular vision is of importance, especially children with higher accommodative convergence ratios are of high risk for myopia development, and the current refraction, especially when the child has or exhibits 0.50 diopters or less of manifest hyperopia at the age of 6 or 7 years. It is very important to acknowledge if the child is less hyperopic than the normal age group, because it should be closely monitored. Usually these children at the age of 6, they develop -0.5 diopters myopia, and by the age of 16, they go to -4.50, and it grows further. Who are the myopia progressors? Actually, that depends on lots of factors. First of all, the younger the child becomes myopic, the faster the progression goes. Also, the family history, the fastest progressors are those with 2 myopic parents. The visual environment, especially near work at less than 20 centimeters working distance for more than 45 years, minutes, and ethnicity, Asians are usually faster myopia progressors. And if we look at the myopia journey, we can say that the journey to high myopia has lots of pit stops for fuel. One of them is myopic parents, but the second stop is less than 60 minutes outdoor time activities. And then another fuel is more than 2 hours a day close near work, more than school work, and then also the binocular vision disorders, especially as a courier. These are the key risk factors which go and speed the way to high myopia development. Environmental risk factors are also of great importance. Ethnicity may be one of them. Asia and countries of Southeast Asia lead the way. Why is that? Because in these countries, they strongly emphasize education and academic achievements, and this leads to a very big demands for near work, and high near work demands lead to myopia and faster rate of progression. And also the level of education is very much connected to the triggering of myopia onset. And it is believed that every additional year of education, if you have it, you are associated with the risk of gaining of minus 0.27 diopter, higher level of refractive error, which is not less. And this is how the higher education you have, this gives you greater risk for myopia progression. Environmental factors can be summarized like outdoor activities, near work behavior, lightening, lifestyle, and screen time, which we spend every day. There are lots of studies. One of them is the New Delhi myopia study, which was carried to see how the myopia progressed. And about 50% of the children progressed because they had more than 6 hours reading and writing a day. They had more than 4 hours video games or watching TV a day. And also 7 hours week screen time led to 3 times greater risk of myopia progression. The only thing which was protective for myopia development was 2 hours outdoor times activities. So if we can say something about outdoor play, this is something which helps children to stop being myopic. Outdoor play keeps myopia away. So this is one of the things we have to consider. Why is that so? The beneficial effect of time spent outdoors is due to the brightness of light exposure, to increased short wavelength exposure, and to the ultraviolet light exposure. This everything is protective for the elongation of the axial growth of the eyeball. Another risk factor from the environment is the near work. And time spent within a working distance of less than 20 centimeters is a risk factor for myopia, which goes also to a faster progression of already existing myopia. Significant association is there between the digital screen time, which nowadays is a constant thing, studying digitally, working, playing digitally, but this is increasing 3 times more the risk for myopia development. We can say that one of the most important overall risk factors for myopia are not so much the genetics, but significantly is affected the time which we spend performing near work, and also years of education, and also the time spent outdoors. These are the 3 main factors, risk factors for progression of myopia. And what we can do to stop myopia, we can do lots of things, as you see on this slide, but one of the most important things we have to do is to make a lifestyle modifications. And optimization of the environment is of greatest importance. So what are our visual environment advices to stop development of myopia? At least 90 minutes a day outdoor activities, 20-20 rule, which is every 20 minutes to take a break for 20 seconds from near work. Eyeball rule, to keep forearm distance between eyes and the book, and the 2-hour rule, less than 2 hours screen after school. Why outdoor activities are so important and protective? Because light stimulation releases a dopamine from the retina, and dopamine release inhibits increased axial elongation. It is found nowadays that every additional hour of outdoor time per week leads to a reduction in the risk of myopia by 2%. And nowadays we have also some programs, FitSight Fitness Tracker, which shows you how to increase time outdoors and in that way to prevent myopia, which is really something very useful. And again, keep myopia at bay, go outdoors and play. This has to be our slogan if we have to fight myopia progression. Another thing which is also important, this is the indoor lightening. And one of the Chinese studies showed that if we increase the light levels from approximately 100 to 500 lux in a classroom, this will lead to will have protective effect on myopia onset and its progression. And also LED light sources are forbidden for children because they can cause possible photo damage on the photoreceptors and also be one of the risk factors for myopia development. So indoor lightening is also something we can change and in that way prevent myopia from progressing. And why is management of myopia so important to us? It is important because every 1 diopter reduction in myopia reduces lifetime risk of myopic maculopathy by 40%. And these are 40% which we prevent from going with significant side devastating complications. Like that, which we see on this slide, you see that in the center of the macula, everything is damaged, and these people actually, they have a very poor vision when this complication develops. Why must we act now in preventing myopia? Because today, myopia affects 27% of the people worldwide, but by 2050, in some Asian countries, the numbers will be as high as 84%. And this is really a very big number. And it is believed also that myopia might be on one of the first leading places of causes of blindness in the world in the near future. So we have to calculate the myopia risk. And there are lots of myopia calculators, right, like the Brienne Howden Institute myopia calculator, which shows you the possibilities of growing high myope. And also another risk calculator, this is My Kids Vision, very useful for parents. So they can calculate the genetic risk, the environmental risk for their child, and overall the individual risk for becoming high myope and try in every way they can to prevent it. And in conclusion, we can say that environment influences a lot of myopia, especially near work, indoor and outdoor activity. They play important roles in the development of myopia and also in its prevention, respectively. There is a strong evidence that less near work and more outdoor activity provide protection against myopia development in the human eye, and in myopia, prevention is better than the cure. Thank you very much for your attention, and thank you being part of SOE webinars.
Thank you. Thank you very much, Christina. It was a really excellent overview of this very complex topic, the risk factors and their possibility of management. So thank you very much again. Now we will move on to our next speaker, Andrzej Srybowski, who will discuss pharmacological interventions in our time. And Professor Srybowski is working in the Department of Ophthalmology at the University of Warmia and Mazuri in Austin, Poland. And Also, he is a member of the European Academy of Ophthalmology. The floor is yours.
Dear colleagues, this is my great pleasure to present a talk on pharmacological interventions in myopia control in 2021. And here are my financial disclosures. None of them is relevant to this topic of this presentation. So also there were some other than atropine substances studied for this purpose in the past, like pirenzepine or 7-methylxanthine, pirenzepine M1 selective antagonist and 7-methylxanthine non-selective adenosine antagonist. And here we see many publications supporting the evidence about the effectiveness. However, they are not in use. And the only substance which is in use, as a matter of fact, is atropine. And this will be the subject of my presentation. Atropine is a non-selective muscarinic acetylcholine antagonist. It inhibits myopia development in both humans and animal models. And in humans, atropine causes cycloplegia. However, the mechanism whereby it slows myopia progression is not via paralyzing accommodation, what was proved on an animal model. And as we can see from the lower part of this slide, it provides the reduction in progression of myopia depending on the concentration and depending on the different studies from nearly 30% for the lowest concentration to nearly 67% for the 0.05% regarding spherical equivalent, and from 12% with the lowest concentration and to over 50% with the concentration 0.05% for axial elongation. And higher concentration, obviously, they can bring even more myopia control with the highest 1% atropine, nearly 80% myopia control. The use of atropine is not a new issue in ophthalmology. Here is a list of many studies starting from more or less middle of the 19th century. We were able to find the earliest study dated back to 1868 by Dobrovolsky from St. Petersburg. However, the modern interest in atropine started with the ATOM-1 study from Singapore, which was published in Ophthalmology Journal 2006. And this study, which was a parallel group, placebo-controlled, randomized, double-masked study, shown that 1% atropine was effective in myopia control after 2 years of use. And however, the side effects of 1% atropine are well known, including photophobia and problems with accommodation. Then the same group from Singapore conducted ATOM-2 study, which was published in 2011, in which they compared low concentration atropine and those 0.5%, 0.1%, and 0.01%. And they shown this study that all of this concentration was still effective when compared to placebo, both in spherical equivalent and axial length. The same group also reported the effectiveness after 5 years of use of atropine, and they shown that atropine 0.01% slowed myopia progression by 50%. And this is well known that the low concentration atropine is much better tolerated than the higher concentration atropine, and it influences accommodation much less, and this also provides much less effect on pupil size. Recently, LAMP1 and LAMP2 studies from Hong Kong presented very interesting data on the use of 0.05% atropine, and they shown that the efficacy of this atropine was double that observed with 0.01% atropine in spherical equivalent progression over 2 years, which is shown at this graph here. The blue line is the atropine 0.05% compared to other concentration. This is the spherical equivalent effect. And and this graph presents the change in axial length. And again, the blue line is atropine 0.05% comparing to other concentrations. Very interesting study was recently presented and published in Ophthalmology journal. As a matter of fact, very recent, it was published just in the middle of October, so a few weeks ago. And this study compared 8 atropine concentration for myopia control in children, and they shown that the ranking probability for efficacy was not proportional to dose, particularly for the concentration of 0.05% atropine that was comparable to that of high dose, like 1% or 0.5%. However, for pupil size and accommodation amplitude, this different concentration, their effectiveness were those related. Here we see the data from this study, and particularly this is comparison between different concentration of atropine, and when we see the atropine 0.05%, we clearly see that it is that the effectiveness of spherical equivalent control or influence on spherical equivalent is even higher than 0.01% or 0.25%, and it is closer to the higher concentration of 0.5% than the other concentrations. And the next graph presents the same phenomenon regarding annual axial length change, and the same is presented here regarding the concentration of 0.05%, which is shown here, and the results are closer to 0.5% than lower concentrations. So, in conclusion, I would like to summarize that with the meta-analysis, which was published a few years ago in Ophthalmology Journal 2016, and at that time, the authors of this meta-analysis compared 16 interventions for myopia control in children, and at that time they found that the atropine was the only intervention providing the highest effectiveness, as you see, clear effects in myopia control by high dose atropine, moderate dose atropine, and low dose atropine. The moderate effects at that time was shown by pirenzepine, as I mentioned, the substance which is not in commercial use, orthokeratology, and peripheral defocus modifying contact lenses, so optical approaches. And the recent review by Cochrane database of systemic reviews from last year supported this evidence, saying that anti-muscarinic topical medication is effective in slowing myopia progression in children. There are much more studies ongoing on low-dose atropine, as you see here from clinical trials database. There are over 20 studies based on low-dose atropine ongoing, and 6 studies based on combined treatment. So we hope to see more data to be included in our practical work soon. And at the end, I would like to welcome everybody to join our European Network for Myopia Control, the group of ophthalmologists who share the experience and knowledge about the treatment of myopia. Everybody interested to join, please contact me by email. Thank you very much for your kind attention.
Thank you very much, Andrzej, for your excellent presentation of this, which is the atropine use is in the center in many practice and very important management possibility of myopia progression, to prevent myopia progression. So thank you very much again. Now we will move on to our next speaker in this afternoon, Beata Tapasztó, who will discuss optical interventions and combination therapies. Dr. Tapasztó is working in the Department of Ophthalmology at the Semmelweis University in Budapest, Hungary. Please.
Good afternoon, dear colleagues. Thank you for the invitation. It's a pleasure to hold a presentation about optical interventions and combination therapies. Optical interventions are very common in myopia control. Both will be obvious to you, spectacles and contact lenses. The two most popular hypotheses for myopia control effect are reducing accommodative effort and lag during near work, and to induce a myopic shift on peripheral retina. The role of the altered higher order aberrations cannot be excluded. Here you can see the second theory in more details. The first panel shows a position of an image shell of a distant object in case of myopia. The middle panel shows that traditional correction provides an optimal central vision, but doesn't correct the relative hyperopia on the periphery, which may lead to eyeball elongation. And the right panel showed the aim of the peripheral treatment strategy, which provides an optimal central vision and at the same time reduce a myopic defocus on the periphery, which reduce eyeball elongation. As you can see in this picture, this young boy is enjoying wearing his spectacles because spectacles are non-invasive and easy to use. Under-correction of myopia with spectacles has been common practice for many years. The theory is to reduce myopia progression by reducing the accommodative demand during excessive near work. But this strategy doesn't provide an optimal distant visual acuity, which may lead to behavioral changes, such as a reduction in outdoor activities in some children, which may increase myopia. So under-correction is not beneficial and can be harmful. Studies have shown that bifocal spectacles and progressive additional lenses has a small effect in slowing myopia progression. This effect was greater in children with higher myopia, with accommodative lag or near esophoria. So we have better effect in myopia control in other interventions. For example, here is the peripheral defocus correcting lenses. All the three famous companies, Zeiss, Hoya, and Essilor, each has a different approach to the design. Zeiss was the first to research and develop his strategy, but their results showed reduction effect only in younger subgroup from 6 to 12 years, and with a parental history of myopia only in a 1-year trial. And there was no enough effect on the eyeball elongation. Along came Hoya, a novel spectacle lens designed by Hoya with BIMS technology and with a myopic defocus of 3.5 diopters has promising results, not only in refraction, but axial elongation as well. 20% of the children had no progression during the 2-year study period. The third company is Essilor. Essilor has just given a summary of their results at World Society of Pediatric Ophthalmology Congress in September. The 2-year study compared different aspherical lens design, and the highly aspherical lens design had quite good results, about 50% reduction effect, both in refraction and axial elongation. So what is the recommendation for spectacle use? Children should be encouraged to wear their full myopic correction all the time, because we would like to avoid undercorrection. And spectacle with peripheral defocus designs are preferred, so they are available now. So after spectacles, let's talk about contact lenses. There are different types of contact lenses in myopia control. There are day wear, night wear, soft and hard. The soft lens design often include a central distance focus and a peripheral rings with weaker power. And the concentric lens design showed better control over axial elongation than progressive lens design. MySight, a multi-zone design contact lens, produced lower myopia progression and axial elongation in a recent study at 3 years compared to spectacle use. And we all know the role of orthokeratology in myopia control. Various clinical studies have demonstrated the effectiveness of this night-wear rigid contact lens. There is an about 50% reduction in the rate of axial elongation, but efficacy may decrease over time, and likely to be there is a rebound after discontinuation less than 14 years. If orthokeratology hasn't got enough effectivity, we can customize this type of lens. The aim is to bring more plus power inside the pupil and achieve a greater shift in relative peripheral myopia. How to select between contact lenses, day wear, night wear, soft or hard? Soft multifocal lenses are preferable for any patients who have less than 2 diopter of refractive error and who have a photopic pupil size smaller than 4.5 millimeter. Because in case of low myopia and in case of smaller pupil size, without customizing the contact lens, orthokeratology has not enough effect in myopia, in myopic shift on the periphery than some soft lens design. And there can be complications of wearing contact lenses, such as overnight use of any type of contact lens is associated with a higher risk of macrobial keratitis than if used it daily wear. But evidence suggests that orthokeratology is a safe option for myopia retardation, and the risk of severe keratitis is similar to other overnight modalities. In 2015, Professor Barrymore was an invited speaker of the European Orthokeratological Society. And he mentioned that the probability that over 1 year, at least one macrobial keratitis case will be observed among 1 patient is 0.2%. If we have 100 patients, it's increased 18%. And if we have about 500 patients, the probability that we will have 1 severe macrobial keratitis case will be observed increased 63%. So the higher the number, the higher the risk for severe keratitis. And of course, there are combinations of the different therapies. Mostly optical devices are combined with different concentration of atropine. Because due to dilated pupil, the myopic defocus effect of optical devices is more pronounced on the peripheral retina. And the combination treatment slows myopia progression significantly more than each treatment alone. For example, orthokeratology combined with atropine seems to be more than twice as effective than ortho-K alone. And what about the future in treatment combination? The future is a contact lens-based drug delivery system, which means that contact lens is able for prolonged release of medications, for example, antimuscarine drugs such as atropine or pilocarpine. So we are waiting for new research to find the optimal intervention or combination therapy for children against eyeball elongation. Thank you for your attention.
Thank you very much, Petra, for a fantastic overview of what is actually a very complex method of treatment. Thank you very much for what is a very complex method of treatment, but you made a very clear presentation and you made it sound so easy. I think we have now heard that there is really a major crisis on the horizon, and it is very important to look at the guidance, and it's been a privilege to work with Janos on the guidance published recently, and he will now go through those for an overview, and then we'll try and answer a couple of the questions as there are many waiting for answers. We'll pick a couple, the more popular ones, and we'll proceed with that. Janos, your turn, please. Thank you.
Okay, dear colleagues, in this last talk, I will summarize the most important guidances. So we know a lot of evidence-based data on myopia, about onset, progression, risk factors, detection, follow-up, and so on, and also about the different myopia control interventions. However, at the present state of science, we are not able to provide simple algorithms or guidelines because there are a lot of ethnical and geographical differences, even in Europe. And because face-to-face comparisons of the different interventions are not available, and we cannot state an order of treatment, such as therapy of first choice or second choice. That's an important notice from Professor Jonas, written that information is constantly evolving, so one must stay abreast of studies published in the peer-reviewed literature for patients to benefit from the latest evidence-based practice. Now, let's go back. What are the known facts about the myopia control? There are 3 different consecutive steps: prevention of onset, screening of premiopes, and reduction of myopia progression. The primary prevention means methods to avoid occurrence of a disease. In case of myopia, the primary prevention measure is to prevent myopia onset. And more time spent outdoors and less near work, these are the 2 most important measures with the highest level of evidence behind them. And then increasing reading distance and limiting continuous reading, and use incandescent light bulbs instead of LED lamps are important factors. And possibly the use of natural light or light level indoors similar to outdoors might be helpful. All children, and especially children with higher risk, should be encouraged to spend more time outdoors as the key evidence-based strategy that appears effective in reducing the incidence of myopia. Time outdoors or direct sunlight exposure appears to have a protective effect against myopia onset, but not for myopia progression. A minimum of 8 to 15 hours of outdoor activity per week is recommended for school-aged children to achieve clinically meaningful protection from myopia. Children should not be prevented from participating in near work activity, but attention should be given to the following measures: regular breaks, appropriate reading distances without head tilt, and near-to-distance fixation changes while reading with sufficient outdoor activities. The Erasmus Myopia Research Group in the Netherlands recommends complete absence of close-up screen use, PCs, tablets, smartphones, video game players for children up to 2 years old, and maximum 1 hour per day for children up to 5 years old, and maximum of 2 hours per day for children aged between 5 and 12 years. Secondary prevention includes methods to detect and address an existing disease prior to the appearance of symptoms. In case of myopia, to prevent progression to myopia is based on screening children for identification of premiopes. The definition of premiopia is a non-myopic refraction in which a combination of risk factors and the observed pattern of eye growth indicate a high risk of progression to myopia. Who are at high risk? These are children with myopic parents and family members, children with excessive near work or excessive indoor time and insufficient outdoor exposure, and children with a cycloplegic refraction equal or less than plus 0.75 diopters at the age of 6. And here you see the different limits for different age groups. And besides this, insufficient binocular vision and accelerated pattern of eye elongation. The visual complications of myopia are strongly related to axial length growth. Thereby, monitoring the axial length changes should be primary target for myopia management. According to the Erasmus Myopia Research Group, axial length does not have a stable growth rate with age, nor is it similar among the sexes and ethnicities. These curves for European boys and girls give information to estimate the risk of developing high myopia in adulthood. Data from Mehulok et al., also from Europe, demonstrate that axial lengths greater than 23 millimeters at the age of 6-7 years are associated with a strong risk of future myopia. So go back to the secondary prevention measures. So after screening the premiopes, we need to monitor them to follow not only the axial lengths, but also for the refraction, and to intervene in case of progression or in case of abnormal binocularity. The tertiary prevention contains managing a disease post-diagnosis to slow or stop disease progression. In case of myopia, we need to reduce myopia progression by introducing an active myopia controlling intervention. Here you see the most important ones: anti-myopia spectacles, which replaces the older forms of bifocals and PAL lenses, atropine eye drops, orthokeratology, and newly developed myopia control soft contact lenses. And in case of progression, there is a need to switch to combination therapy. Informed consent is an important part of our work, regardless of the specific intervention used. All patients must be informed about the efficacy and potential side effects of different myopia control strategies. In the age of 6 to 12, there is a rapid progression, that is the period of rapid progression. And by the age of 15, almost half of the myopic children are stabilized, and it is most of them stabilized by the age of 24, except highly myopic children. After stopping the treatment, please monitor children for further 6 to 12 months to ensure that there is no further rebound. And there are examples of how to stop treatment here in this slide. And finally, what to do? That is the most important question. In case of the primary prevention measures to prevent myopia onset, it needs health promotion, health education, environmental modifications, lifestyle and behavioral changes, and it needs action from the Ministry of Education and the governments, and there is a need to distribute the information to the people. Concerning the secondary prevention, the premiops, there is a need to active screening and follow-up of the premiops. It is based on mass screening of preschool children, which might be an action by the Ministry of Health and Ministry of Education. And there is a need to increase the population awareness and monitor premiops and intervene is an action of the eye care specialist. And in case of the tertiary prevention measures to reduce the progression, it needs active work of eye care specialists, needs education of them, and needs adequate financing of the interventions, optical devices, and the eye drops. Based on the advices, we might formulate different key messages for different target population, for eye care specialists, for parents, for children, for politicians, for decision makers, and so on. So please remember that the high number of myopes will further increase in Europe unless we act now, and we have to need to act now. Thank you very much for your kind attention.
Thank you very much. Thank you very much, János, for another fantastic presentation. Thank you to all the speakers for keeping to time and for really bringing home the huge problem we have on our hands. It's a real wake-up call. I can see many questions, mostly revolving around the use of atropine, what concentration, for how long, the rebound effect, etc. I hope that we'll be able to answer most of the question electronically. But if you have about 1 minute left, would one of the speakers wants to sum up the strategy for atropine and perhaps why we should try and put pressure in different parts of the world for making sure that atropine is licensed, because the challenge we have is that in many parts of the world, atropine is not yet licensed for the use for treatment of myopia. János, would you like to answer that question, or
I
think Professor Andrzej?
We might ask Andrzej to ask.
I think it's very.
You have only 1 minute.
Yeah, this is very long, answer, and the majority of this topic was already covered by the great concluding presentation by Professor Nemeth. So I think that is very difficult to add anything. We know that there are some trials ongoing, and hopefully soon atropine will be available on on-label basis in Europe and in other parts of the world. So this is about atropine. Fortunately, we do have now some other methods, optical methods, that they will nicely presented. So we can also probably in the nearest future start to use combination treatment with eyeglasses or contact lenses and atropine. This is probably the future. Finally, we should be as effective as possible, providing as less side effects as possible. This is probably the strategy we need to follow. In short, in just a few words.
Thank you very much. I hope that many of the questions could be answered electronically later on. It's been a fantastic webinar. I think I must thank all the speakers for really bringing home how important this problem is. There is clearly urgency in getting some kind of regulated treatment, and we can't afford the time because there is a time bomb at the moment. I hope that all the listeners will agree that the speakers should be congratulated, and I sincerely hope that what they've heard this afternoon will help them reconsider what they're doing or change their practice or share within their own country and across Europe their practice so that we come up with the ideal solution for this huge problem. Thank you again to Janos for putting together this fantastic webinar, and thank you to all the speakers for excellent presentations. Thank you.
I would like to say a few words at the end. Our time is now up. And I also would like to thank all our presenters for sharing their experience with us, and all of you for your continued support of SOE. So today's webinar has been recorded and will be available in the SOE website shortly. There will be a very short survey at the end of the webinar. Please take time to complete this. Thank you all for your time today. Please stay safe and healthy. Goodbye.